Good morning and a very warm welcome to Bonitas House Call here on SABC2. Bana ba mangkhawuliseni mthwana. Bantu abakaphala. Babandla kamjokwane kandaba. Zolomnyama njalo simhlophe. Sithi kunina nonke sikhulekile ekhaya. I'm Dr. Victor Ramathesile. Mina ngilukisetsang ngaka katlu. Le tlang wena he Saturday se se metsotso ha ile mashome mararo re furaletse hora ya borobedi hoseng. Now the spinal cord, which is pretty much the tail of the brain, is housed and protected by the spinal column, which extends right from the back of our heads up to the lumbar area. Now, nerves that come out of this long structure are responsible for the functioning of our arms, our legs, and many other activities such as procreation, as well as bladder and bowel control. But what we often forget is that any slight disturbance and injury to the back can easily affect this brain extension, leading to permanent and disabling paralysis or loss of function, which brings us to the subject of our discussion today, paraplegia. Simply put, this refers to loss of function in both the lower limbs. Now, as you welcome your calls on 083-913-4687 with your questions and comments on paraplegia, or you can send your SMSs to Bonitas 33723. Now, our Bonitas house call team went out, baphume sebephunga ngeyithebe ukuyozingela nokuzibonela ngo-C izinkinga ke ababuye bahlangabezane nazo abalimele umfunkulu phecelezi i-spinal cord baze bakhubazeka ngale ndlela okuthiwa ngumthwebulo. Yiza nendlebe size nendaba. Let's watch this report and see exactly what happens in this area.
Igama lami nguSakhile, ngibuya eNkandla. KwaZulu Natal, ngisuke KwaZulu Natal ngeza eGoli. Ngahlala Alex about 1 month ngihleli nje ngathola umsebenzi. After 1 month yakhona ngabo June. Nge-2 zika June ngathola umsebenzi ngasebenza eSantini eNanda. Ngisebenza construction ngenza waterproof from roofing. Kusho ilanga lakhona ngabo 9, so besithatha lunch ngabo 9, i-2 time ngabo 9. Basiqeda kudla like mina ngingabuyela ngagibela ngaphezulu la besebenzela khona. Abanye umunye umfana engisebenza naye owangilandela uye umuntu owakhwesta ukuthi ngilimali ngiwe like yabo wayenza ama-action nyana lapha kimi, and then lana meeting zami ukuzivikela khona kanti la sengizolimala khona ngawa khona. Ngiwe from double story on the roof, wangibizele ambulance, and then wafika ambulance angithatha ngisa e-hospital, and then ngahlala like maybe 6 weeks ise-ICU ngaya eKensington e-rehab for training yonke into because bengakhona ukukhuluma, ngiyofunda nokukhuluma ukuthi ivoice iphume, and then ngikhani ngasuka lapho ngaza e-home eSoweto. Ya la ngiqale khona ukuhlala ke ukuthi ufunde impilo, start impilo engcono. Ngavolunteer la eSoweto Shesha home. Ngavolunteer kuba i-receptionist. Abodokotela bayangitshela ukuthi kuthatha isikhathi ukuthi ngihambe more than 10 years or 20 years, but ngenze ukuthi ngihambe, ngenze ukuthi ngaba ngisahamba, but kumele nje ngingaluzi hope yabo. Soweto Shesha home mina bengingayazi, ngingazi i-Randburg. So Soweto Shesha home ngiyazi nge-social work yaseKensington. Iyo ngifundela indawo la eSoweto Shesha home.
Oh, hayi usendawo kwahlala ngempela. Sisotho seritsietsi ehlaha mabaka ofokolo. But I must say I marvel at how our brother here has taken his disability in his stride with no self-pity but a very positive attitude and outlook. Kuyabonakala ukuthi indoda yakithi yale kwada kwadunuse kwampinda amshaye kwesikamshuluzi madoda inkandla ekhandla amadoda ukuthi hayi iyasebenza ngempela enogqozi lokuthi iqhubeke nempilo. Now let us welcome into the studio Dr. Velemina Makambeni, who's a neurosurgeon at Charlotte Maxeke Johannesburg Academic Hospital, as well as Dr. Francois Teron, who's an orthopedic surgeon and the chairman of the Southern African Spinal Cord Association. Colleagues, thank you very much for joining Bonitas House Call this morning.
Thanks for having us.
We're talking here about a very, very common condition. What is the average number of people in South Africa?
That's a very good question, Victor. We actually don't have any national statistics because spinal cord injury as a whole is not a notifiable disease. So it's a difficult one to answer in that there's no national database. So we know that we have a very high incidence. International statistics say that we should average about 40 per 100,000 of population. But I think we know we have a very high incidence of trauma-related injuries in our country, and as well as the burden of infectious diseases, which all attribute to or can contribute to spinal cord injuries. So in the short answer is I don't know exactly what our national statistics are, but that it should be in the region of more than 40 per 100,000 of population.
Now, Dr. Makambeni, we know that for the spinal vertebral column to be injured, so that because the spinal cord is right inside, and we'll be looking at the sample that we have now, that you have trauma or injury on the one side, and then you have other causes, infections and whatever. Insofar as trauma is concerned, what is the commonest cause of spinal cord?
When referring to a study that was done, published in 2007 by Grooteskir, they believe that motor vehicle accidents are the most common cause of significant cord injury, particularly in our case we're talking about paraplegia. That's so far as South Africa, around the region of 56%. Subsequent to that, they come falls from heights, significant heights. And then we, in our country, unfortunately, assault is a serious problem. Interestingly enough, when you compare our figures, though, to, for instance, the Americans, we're slightly lower, we're around 6%, with assault being a cause. And then overseas, they see more than 10%. However, motor vehicle accidents, falls from height, and then, of course, subsequent to that, interpersonal injury, including sports injuries, blast injuries, penetrating injuries, and as we said, blunt trauma in the form of assault. And
non-trauma, are there diseases? I know tuberculosis of the spine quite common in this country. It can also lead to this problem.
Quite true. Professor Modi and his colleagues did a study at Kritsani Baragwanath Hospital, which was included in a textbook written in 2012 about the African condition as far as non-traumatic paraplegia is concerned. And they found a fairly even spread where about 50% of patients coming in with non-traumatic paraplegia were essentially patients who have an HIV-associated condition, usually your younger patients, and then roughly the other half are patients who are generally older, have more degenerative type problems. And as you'd said quite correctly, about 80% of the younger group, the more HIV-associated group, tend to have tuberculosis of the spine. Whereas in the older group, you have, as mentioned before, degenerative diseases, and then, of course, tumors of various forms.
Various cancers. Okay. Before we get confused even further, here's a piece of sample. Can you show us exactly what happens and how this structure is important and what happens when somebody gets injured or gets a disease that leads them to paralysis? Can you show us?
Sure, you must help me if I don't remember, but basically what you see here is the spinal column, the vertebral column, the bone stretching.
Okay, can make it face that way?
That Correct. Way better.
Yes, that's fine.
Okay, you've got your bones stretching from C1 at the top, which is just below the brain and the skull, down to L5, which is at the bottom. You've got 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. Okay, that constitutes the bony architecture of the spine. Okay. Inside the bony column, you can see the yellow things demonstrated.
So those yellow things are nerves that are coming out of the spinal cord. Yeah.
Inside.
So the spinal cord runs inside that hollow structure. Okay.
Inside that column. And an interesting fact is that in the adult population, the spinal cord actually ends at about L1.
I see.
And from there on, you have peripheral nerves running out, and at each level, a nerve comes out that's does different functions to, as you said previously, supplies the lower limbs and the upper limbs. Now, interesting, our patient that we saw earlier probably had a more cervical injury because his upper limbs were actually affected, and we should differentiate between paraplegia, which means two affecting the lower limbs, and quadriplegia, which is four.
Can you just emphasize one thing before we go to the end break? So it means all those yellow things are nerves that are coming out of the spinal cord.
Correct.
And these nerves are responsible for supplying the various parts of the body. And by supplying, we mean they're responsible for the muscles to function properly. They're also responsible for sensation, because without those two, you won't be able to function.
You don't function.
Now from high up in the neck there, they supply the upper structures in the body.
All the ones that come out on the neck vertebra actually supply function to the upper limbs
arms and
the arms. The ones that come out at the chest supply the respiratory muscles and the intercostal muscles that help you with breathing.
Okay.
The ones lower down from the lumbar vertebra run down to the legs, and so they supply the muscles of the legs, as well as bladder and bowel function, which is
quickly, Dr. Makambi, before when you're in an accident scene, somebody has injured their back to the point where the spinal cord gets affected. What actually happens to you there?
All right, you have, it all depends on the nature of the injury. Okay, you have flexion type injuries where the head and the neck and whichever area of the spine is involved bends forward, okay? And then you have extension injuries which go backwards. Sometimes, let's say a patient were to strike against something, then those would be compression type injuries and burst fractures where it's
Let's hold it there. We're going to take an ad break. When we come back, we want to know exactly, as you injure various parts of the spinal column, what happens to you, and exactly how you guys manage that when a patient comes into hospital, and how you manage that, like our friend here, for the rest of his life, what exactly you are going to do for him. Barnabas, it is always advisable to exercise extreme caution when you are moving injured people at an accident scene. A di hlokomeleng haholo jwang ha re fihla bathong ba lemetseng dikotsing tsa makoloi ho ba suthisa bahlasipa ana ka tsela e bohlaswa ka qetela ho entse motho ra ba holofale ditho a ska kgona ho hlola lo tseba ho tsamaya. We'll continue our discussion on paraplegia hang hang re khutla papatsong ha ra matheola. You stay with us. Re thobela o lena gape ka mo gae mamatlhae re tshwareng taba ewe ya kgobalo ya mokwatla e ka feletsang namilwe motho a le paralyze ba bangwe ke motoro ba bangwe ke sethunya kgane ba bangwe motho wa ntse o nobela ga ntse a le ka ona mogona o re gopela le re tshwara ka moteto mo nomorong ya 0839134687 go ba borifele bo boripane ba reng ke SMS o no thoma ka Bonitas ke moka wa bo re 33723. Now let us just get Dr. Makambi. PR Makambeni, Mamelodi, the legendary doctor, related? Don't laugh, don't blush now.
Yes,
are you related to him?
Hi, uncle.
Oh, he's your uncle. Okay. So these Makanis are, I think they're attracted to the profession. Fine, let's get to the deal of the matter now. We said a little bit earlier, there's the spinal vertebral column, the spinal cord is running inside. Here are the nerves that are coming out. And said various insults to the back, whether it is by disease. The most common, we said, is tuberculosis. Tuberculosis, we all know, is the most common opportunistic infections in people who have HIV and AIDS. And South Africa, we have the highest incidence and prevalence of this condition in the world. So it is something that will creep into any discussion that we have. But just tell us, from the neck, which is the cervical spine, to the thorax, which is what runs through the chest, right up to the lower part of the back, which is the lumbar spine. What happens as and when you get insult injuries or disease in those parts? What happens to the rest of the body?
Well, basically we can divide it, if we start at the top. If you have an injury above the third cervical vertebra from the top, so above C3, the patient will have no function in his upper limbs and will have difficulty in breathing and will be dependent on a ventilator because... So that's a very life-threatening condition.
Before you even scare us. So basically, if you have an injury to the bones,
C3,
it eventually affects the spinal cord that is
causes
inside.
pressure or trauma to the spinal cord, And then those nerves don't function from there on down.
Is that permanent once that happens?
Well, actually, it's not as easy to predict because it's very seldom that you get a complete injury in the spinal cord. You have to remember the nerves are very tiny structures, so certain ones might be damaged, other ones might not be damaged. So it's seldom that you get a complete or a total lesion. You can, and then they happen, but it's actually you get a wide spectrum of injury to the nerves.
Okay. In the interest of time, so you said anything above. So once you are injured, anything below that stops functioning. The whole spinal column stops functioning.
Work. Yes,
Scary
definitely.
Stuff. So anything above the third cervical spine, you cannot even breathe.
You won't be able to breathe. You'll be dependent on a ventilator.
For the rest
for
of
the
your life?
rest, if it's a complete injury, if there's no recovery, yes.
Okay.
Between C4 and C7, so in other words, those bottom parts of the cervical spine, you'll have varying function in your upper limb. Some muscles will work and some won't work. For instance, if you have a C5 injury, you will still be able to bend your arm, but you might not be able to lift your wrist or to straighten your arm.
I can see that you work in this area and you have a very positive outlook to what happens. But can you put it simply? If you get injured anywhere in this area, you'll be paralyzed, both your upper limbs and your lower limbs, and everything downwards will be paralyzed.
Yes, correct.
There will be exceptions, of course, depending on the degree of injury.
Correct.
As you get lower down, what happens?
If you're injured below the cervical spine, in the thoracic spine, your lower limbs won't work, and your abdominal muscles won't work either, and certain of the intercostal muscles, in other words, the muscles between your ribs that help you breathe, won't work, depending on how low you go down into the thoracic spine. The lower you go down, the more muscles work downstream. If you get to the lumbar spine, again, it depends on where the lower down you break, the more muscles will be working, and the higher you break. So for instance, if you break your second lumbar vertebra, you might still be able to bend your hip, but you won't be able to straighten.
And what about bladder function? What about your bowel function?
Bladder function is actually comes from the sacral nerve roots, which ends up at about L1, but they are invariably damaged in all of these injuries.
Which is why a lot of the people who have had motor car accidents who are sitting on wheelchairs, they can still use their arms, some of them.
Correct.
But going to the toilet and urinating and all of those things.
They can't do, yes, or they have difficulty, and we have to teach them how to manage that.
Oof. Abdullah, you're joining us from Palm Ridge. I think this is somewhere around the Kempton Park, Midrand area. Thank you for joining Bonitas House Call. Good morning. Abdullah. We've lost Abdullah there. He'll possibly come back. Abdullah? Okay.
How are you, doctor?
Oh, we're good. Yourself, Abdullah?
Yes, doctor. I need assistance when I went to various types of stress.
Yes, Abdullah, we're listening.
Every day, so I feel a pain in the neck every day and at the back. Actually, just like now, more in pain. But now, I also go to massage place. I went to physiotherapist. I'm not getting that anyway. I don't know. Maybe it's a problem with my spine. I don't know really.
No, hang on, Abdullah.
Please advise me because I have tried everything. Now I'm despondent. I actually don't know what to do. When the children tried to rub me at the back, I went to the physio last time. They're not working anything. The tablet's not working for the pain I have at the back.
Your line, unfortunately, is very bad. Did you hear what he's saying? Did you say you're injured?
So the line is quite a bit bad.
Jeez, I can't hear.
Hello?
Abdullah, unfortunately, your line is not very good, my friend, so we won't be able to be of any assistance. Have you injured your back? Yeah, no, it's a very bad line, unfortunately. But okay, having said that, now when you are confronted with a patient on whom you suspect a spinal injury or a spinal problem, typically what do they say when they walk into your rooms or when they're brought into your rooms?
Well, it usually depends on the site within the spinal column, as you said, and cord that is involved. Usually if it's a bony problem or a problem with the lining of the cord, they may complain of pain or irritation which is sensitive to movement. So it gets worse when they perform certain activities or when they're in certain positions. Sometimes you find that a patient has a diseased bone, for instance, and suddenly fractures that after very minor trauma, and then subsequent to that, the pain just becomes worse and worse and worse. However, there are those patients who then may have an actual cord problem. Now that again is also very variable. It also depends on which area of the cord is involved. Usually those patients tend to have less focal pain, as in over the back or cord or the spinal area itself. However, they may talk about either loss of sensation, pain, or functioning problems which are from the area that's affected downstream of that, as Dr. had explained.
Now, if you have a patient, for instance, then typically, I mean, you have 56 or so % of most of the patients with spinal injuries in this country coming from motor vehicle accidents. Now, typically, this is what happens in a motor vehicle accident, and how do those patients present it? How do you identify them, and what do you do with them when they get to hospital for the first time?
The important thing about polytrauma or patients with potentially multiple injuries is that you always have to do at least the basics first. You need to ensure that the patient can actually breathe and oxygenate all the areas in their body as well as possible. You need to try and double check that the patient can get blood flow to all those areas, does not have a major injury and is bleeding onto the roadside or in the casualty area. So those are the basics, because sometimes if those are not controlled properly, they can give you false symptomatology elsewhere, where you find that it's just a matter of the patient not being able to get blood flow or oxygen to certain areas, and then you don't know what you're dealing with. So it's always very important to deal with those life-threatening problems first and foremost. And then, of course, come the various complaints the patient may have. You might find that the patient notices that they can't really move a certain area of their body as well as they used to. Sometimes, however, they're distracted by pain elsewhere. And then those things may only become evident later on. It's important when there's the primary assessment, as I said, which deals with the life-threatening problems, but then of course there's the secondary survey where they double check that there's no major deformity of certain areas. They check that their sphincters are working as one would expect for them to be working.
Let's hold it there. Hold it there. When I come back from the break, I want us to be a little bit more simple, because what happens is that when people come to an accident scene, there's a lot of panic, there's sound, people are crying all over the place, and most of us are not medically trained to understand all of this. And what we need to do is that there's an assumption that a lot of people are moved wrongly during accidents, and injuries that otherwise could have been managed properly can be made worse by just moving them around. And some people, there's evidence that actually get paralyzed in the process. So what we need to do is to identify those high-risk patients and say to the public what it is that needs to be done to ensure that we don't exacerbate or even worsen injuries that already have, so that we can render some people paralyzed when otherwise they would not have been had we done certain things properly. We'll run up our discussion after the break, but we would like to remind all our viewers that the annual Summer Bonitas House Call Doctors Awards will be held on the 16th of August 2013 at the Birchwood Hotel and the Conference Center. We'll now look at how government and families and society in general look after paraplegic patients, similar disabilities, when we come back after the break. Welcome back. You're watching Bonitas House Call here on SABC2, and today we are talking paraplegia. Let us now see some of the support and services available to people living with this condition, and in our societies, what exactly we do, how we look after these patients. Let's watch.
Cheshire Home was founded by a group captain, Leonard Cheshire, who was a World War II pilot. He studied in England just after World War II, and then came to South Africa in 1965. The Soweto Cheshire Home offers accommodation to people with disabilities who cannot go to live with their families. When they come here, they are taken through counseling. We've got a social worker who's on the premises who does counseling, and then other people with disabilities as well who have succeeded they also go help with counseling because they understand the situation of disability better. Within the home, we have got projects that we are doing. We get jobs from companies who bring the jobs here within the center. Currently, we've got work that is being done by 13 ladies who are employed with a decent salary. Some of the residents go out to work. We've got 4 who works at Helen Joseph Hospital, and we've got 1 in Baragwanath Hospital, and then others are working in the corporates outside. Mainly we rely on donations, but with the economic situation currently, it is very, very difficult to survive. But the government does give subsidy, which covers only about 30% of the budget. And then our residents as well do contribute part of the budget. We don't actually provide medical care. If somebody is sick, we take them to hospital because we don't have the capacity to provide medical care. What we do is we work with local clinics and hospitals. That's where we take our residents for medical care.
The challenges that we faced with, it's currently the money. We don't have sufficient money to cater for the needs of our beneficiary, and also to open other things that we need to do in future. For instance, the charity shops. For instance, to have other activities running within the homes. Probably it can be a ground, or probably it can be something like a hall whereby we can have activities running throughout the home.
We've got about 7 people who are paraplegics within the home. We've got other different disabilities within the home because we cannot discriminate against other disabilities. We take everybody within the home. We work with social workers who refer people to us within the home. What usually happens is that when somebody is injured and they are in hospital and the doctors have confirmed that that person will never walk again, we'll be contacted to go there as people with disabilities to talk to that person and tell him or her how we have survived the issue of being disabled, and then make them understand that there is life after disabilities. If the family cannot take that person home, that person will be brought into the home as a last resort. But we don't encourage people to come to live within the home because our aim is to bring them here, rehabilitate them, and then reintegrate them back into the mainstream society. I would like to say people with disabilities have got to know that there are 3 homes here in Gauteng that are there to help them with whatever problem they are encountering in life. So get involved, contact Cheshire Homes. Cheshire Homes will be able to work with you to improve your life.
We'll obviously want to encourage all South Africans who can to contribute to such worthy causes as this one. You can see the amount of work and the service, and as well as the support that organizations such as this can give to people who are otherwise paralyzed and unable to do certain things because of paraplegia that we are talking about today. Columbus, you are joining us from Johannesburg. Thank you for joining Bonitas House Call. Good morning. Yes, Columbus.
Yeah, good morning, sir. How are you?
Good yourself.
Yeah, I was involved in an accident. I fell inside a deep well in 1975, a 50-feet deep well in 1975, and then I was young, nothing could happen to me, I could not feel anything. Now, I started having a serious pain on my lower waist. Then I went to the hospital, I was expressed, and they discovered that one of my bones by the side of the lips shifted. And the orthopedic doctor told me that there's nothing they can do about it, that it's older now, and the only thing I have to do is that they referred me to the physiotherapy, which I had been going, and up till now, I have not been able to sleep on the bed. I sleep on the ground, no matter the weather. And each time it's cold, it becomes a very serious problem for me. Like I'm talking to you now, I'm having a very serious pain at my right hand of the lower waist.
Columbus,
I eat a lot of food.
Columbus, Columbus, do you still have function of your lower limbs?
Yeah, down to the waist,
You can walk?
Yeah, I can walk. Yeah, I can walk.
So it is a pain that you have now?
Sorry?
Your problem is the pain in the lower back.
Yeah, right to the lips.
Okay.
One of the lips are the lower lips shifted according to the X-ray.
Yeah.
Yeah, shifted and it gives more space than the other spaces.
Okay, but you can still walk. So this is not necessarily paraplegia. So this is
What it sounds like is that Columbus has a degenerative condition of his lumbar spine, I assume. I couldn't hear that bit well, but you can see on the pictures that
you want to use the stick there
yes.
as a yeah.
It can either be affected by trauma, as demonstrated on those pictures there, the bones can break, or in a degenerative condition, the little cushions between the vertebrae can become worn out.
Can get squashed, yeah.
And then they move, the vertebrae can shift, and that causes pressure on the nerves coming down.
But
it can cause
so
pain.
it can cause pain, but not necessarily paralysis, or it can if it left untreated.
It's very rare for that to cause paralysis, but it is a possibility. I would say the statistics is less than 0.2% that you will have become paralyzed because of a degenerative condition, but it is possible.
What advice would you give Columbus?
I would continue with the physiotherapy, manage the situation as adequately as possible with analgesia and physiotherapy. If it doesn't improve after a period of 3 to 6 months, he should consult his primary surgeon again and see if there's possibly some operative relief that can be given to him.
Dr. Makambe, now I want us to do like first aid 101. A patient like our friend from Nkandla there who got injured, fell from somewhere, a patient who has been in a car accident, how do you identify somebody who might have had or who might have sustained a spinal injury? How do you suspect that, and how do you manage that, not as a doctor now, but as a layperson?
Any patient with multiple injuries should be presumed to have a spinal injury until proven otherwise.
Okay.
That's the safest thing. Because as we'd mentioned before, sometimes you have other distracting injuries. The patient can't really tell you that I can't move my leg because they have this major pain over their chest. So you keep the patient. The safest thing for the public, for instance, if it's at the roadside, is to try to keep themselves safe and to minimize, let's say, if there's traffic, if there may be triangles that they could set about to redirect traffic, if anyone has some in their cars, that would be the safest thing. Minimize moving patients because you try to keep them in line. It's easiest with equipment that usually emergency services personnel have at their disposal. But as a member of the general public, we probably would not have a spine board. So just keeping the patient in line on the ground is the best thing that
And
anyone
don't
can
move that
do.
patient.
That's the safest thing for everyone.
Okay. Now, when that patient gets to hospital, patient suspected with a spine injury or patient is lying on an accident scene or after a fall, you assume that they have a spinal injury. And as a layperson, don't do much. Just make sure, like she says, that there's no other danger, there's no fire. Make sure that they are not bleeding actively in any areas. Deal with that, but don't move the patient until properly trained paramedics arrive on the scene. And when they get to hospital, what do you do exactly to those patients?
Well, the first thing is, as Wilhelmina said initially, you make sure you stick to the ABCs. In other words, you make sure the airway is good, that they're breathing properly and they're not bleeding from any other major wounds. Once that's been done, you then examine the patient through a secondary survey. You see if they can feel everywhere, all their different limbs. You can...
Okay, let's move quickly in the interest of time. Once you've made a diagnosis,
Yes.
you have checked them, you can see that they can no longer move their lower limbs, or they can, unfortunately, some of them cannot move the upper limbs, like it happened to popular singer, the late Teddy Pendergrass, or, Max Brito, who was injured during the Rugby World Cup in 1995, got into scrum at the collapse of the scrum, injured his neck, and has remained quadriplegic with all 4 limbs not working ever since. And many other situations. Now, once you've made an assessment, you've assessed that patient, and you know that this patient now is paraplegic, they're paralyzed from the neck down or from the hip down for the rest of their life. How are you going to manage that patient going forward?
Well, firstly, you do x-rays. You make sure if there's a fracture, whether the fracture is a stable fracture or unstable fracture. So we have x-rays, we have scans done. And if it's an unstable injury, we can perform surgery to stabilize the bony segments of the spine, in other words the broken vertebrae. We can fix those and relieve the pressure that there is on the spinal cord. So if there's any fragments of bone causing pressure on the nerves, we can remove
In
that.
other words, you're trying to prevent further injury.
Trying to prevent further
When you come back
injuries.
from the break, we are going to look now at how you deal with possible problems in the first year and how you deal with that patient for the rest of their life. Those are good. Khawulezani ke nisicalele emnxeba kaNomya iselfoni ngokutsho ku-083 913 4687 sive imvo ngalomba esithetha ngayo nganamhlanje emva kwevenkile after the break. Welcome back. One is research rapid council Mona Bonitas house call or SABC2. And today we are talking about paraplegia or spinal injuries. We are joined by Anonymous from Tembisa. Thank you for joining Bonitas house call. Good morning.
Good morning, and how are you?
Good yourself, sir?
Yeah.
Can you raise your volume a little bit?
Yeah, I was injured at 1972 at my spinal cord. I was stabbed at my spinal cord. I've been in a wheelchair for a year at Tembisa Hospital. And then I recovered. I was back into training and all this. I woke, I wept. And then now, because of my age, I'm retired. My only problem is the injury that I had is affecting my nerves, and my walking movement is getting more bad. I don't know what to do because I'm scared of doing the operations and all that.
How old are you now?
I'm 61 now.
Now, you went to the doctors, and what did they say exactly is responsible for the pain that you have?
Think my spinal cord is affecting my nerves.
Okay. And you're scared to do the operation?
Yeah, I'm scared to do that because I don't know what will be the consequences of it.
Dr. Teron, without knowing the details of Anonymous, thankfully for him, he had a stamp on the spine. And typically those will recover unless it is a very deeply penetrating wound, isn't it?
Well, yes, if it damages the nerve and he was paralyzed, that is unfortunately a permanent injury. But I think what it sounds like is that he's partially recovered and is able to walk short distances. But as you get older and certain nerves aren't working, you degenerate either your hips or your lower back because you have abnormal movement. And the aging spinal injured population is a huge problem.
Would you say he mustn't be scared of the operation, or he must, if he's scared, he must stay with the pain? What advice would you want to give him?
I would say that we need to identify where his pain comes from. Is it from a degenerated hip? Is it from a degenerated spine? And depending on what those findings are, we can then treat it properly.
But would you want to reassure him that if that operation is done for the right reasons, and if it's done by the right person, and it's done the right way, there's nothing that he should be worried about?
Exactly.
Okay. Anonymous, I hope you heard that. Now let's look at this SMS quickly. What challenges can a paraplegic woman face during pregnancy? Is it easy for paraplegic women to fall pregnant in the first place?
It is possible. It is possible.
But we've said sexual dysfunction and even total paralysis is especially in paraplegics, especially men. I mean, they don't function at all or to a very limited extent.
Well, it depends on, as Dr. was explaining, where the injury is, how high or how low.
Yeah.
If it's, let's say, far lower down, he specified over the lumbar spine, below L1, you may find that in males, there's very little, if any, function if it's a total injury. However, in females, of course, the patient may still be able to conceive. And in males, if the injury is higher than, let's say, L1, then they will have something called an upper motor neuron injury, where they will still be able to get an erection and function sexually.
I see.
However, in females, there are several problems that one needs to think of. First of all, the delivery and the movement of the lower limbs may be a problem, especially if it's an upper motor neuron.
So they can deliver, but they need special care.
They can deliver, they need special care. They need to be followed up at a center that understands the problems or the challenges that they face. So as they need, the the pregnancy needs to be diagnosed or identified as early as possible, and the patient needs to be she needs to be committed to the follow-up and going to the appropriate centers. Because mind you, sometimes the sensation may be affected and they may not be aware that it is time. So there are all those small details that if they are being followed up in an appropriate center, they can follow up the baby's well-being and also foresee ahead of time if maybe the patient needs to come in electively for delivery of this child.
Now the spinal unit. This is now where you take patients who've got spinal injuries, whether it is quadriplegia, which is high up the neck, and they are paralyzed. I always make the example of the late Teddy Pendergrass because that's one of the most known examples, or it could be just the lower limbs, as could happen in a motor vehicle accident. Now, in the spinal unit, we know that you have the doctor here, who's the team leader, and that doctor must have access to a physician, must have access to a neurosurgeon like Dr. Makambeni, must have access to an orthopedic surgeon, must have access to a urologist, because quite often these people have bladder problems and otherwise. But otherwise, the whole team is comprised of that doctor who's coordinating everything. You need a physiotherapist, you need an occupational therapist, you need a sitting specialist, I'm told. Now, these are people who ensure that these people can sit, because pressure sores is one of the major issues. You need a clinical psychologist, if you can, because the psychological impact of this condition, is too costly to contemplate. Of course, at some point, you also need the social worker to deal with all the other issues going forward. Now, we know that not every hospital has got all of these people. But can you give us a sense of the spinal unit? What is their goal? What it is that they are trying to achieve for the patient who has suffered a spinal injury?
The main goal is to get the patient back to his home environment and work environment as quickly and as efficiently as possible. We were talking about it earlier. We'd like to rehabilitate patients effectively so that they can become productive members of society again, which is entirely possible in most spinal cord injuries. That's, in our opinion, the most efficient way of managing spinal cord injuries. We can spend a lot of money on the acute care, do big operations, stabilize the spines and things, but unless you take care of the rehabilitation as well and get these patients back into the community, back to their families, working in a different, maybe adapted environment, you're not actually achieving your goal, which is to recreate the environment and make them productive members of society again.
How do you deal with bed sores going forward? Because I think this is one of the major problems of patients with
The most important thing about bed sores is preventing them. Of course, when you're in a high intensity set up ICU high care, you have people who will turn the patient frequently and who double check that the skin is in very good condition. At the very least, they will check once a day to make sure that they can see that.
But once they're back at home, how do you do that?
However, that is where the rehabilitation center comes into play. The patient needs to be aware. For instance, patients can be educated that they must essentially also time themselves and change their own positions, because you and I
but they
will
can't
shift.
Because they're paralyzed.
Well, for instance, we saw the patient who had fallen from height could still use his upper limbs. He may not have sensations over the lower limbs. However, if he is educated properly, he knows that he needs to reposition himself. Because you and I can feel that I'm getting a little uncomfortable now.
But they don't have that luxury.
They don't necessarily
so you have
feel
to teach
that.
them to tend
so they
themselves
have to learn that. If a patient has far higher problems or the upper limbs are also restricted, the family needs to be involved.
Okay, let's
so
hold it at that.
rehabilitation is
Because
everywhere.
they do really have many problems, and unfortunately we don't have enough time to look into those, how the bowel movements, how they control urination, because they don't have sensation to know that it's now time to go to the toilet, and that is a very major issue that they have to deal with in the immediate phase, and also when they get back home or in the center that we saw in the inset, that they need to be managed in that sense. This is where the supportive groups come into play, and the support of the family also comes into play. Would like to remind our viewers of the South Africa Annual Medical Awards, Bonitas House called Doctors Awards, which will be held on the 16th of October, remember, 2013 at the Birchwood Hotel and Conference Center. It is quite clear that spinal injuries or the spinal cord is very important, and yet a very delicate organ with very limited, in my view, anatomical protection against the dangers of our daily activities. Please treat your spinal cord with caution at all times. We'll round up our discussion on paraplegia when we return. Watching Bonitas House Call here on SABC2 and welcome back. Mogaiso, mogwangwile borwa mo re konotela go ba moroko ka mafoko a tshedimosetso go tswa go baitsanape ba o re mo re baladitse mo mosong wa gompieno. Now quickly, the future of the management of paraplegia in this country.
Exciting. Very exciting. It's a developing field. I think in a couple of years' time we'll be able to do a lot more than we are currently, but it's going to take a lot of dedication and a lot of centers where they are managed properly throughout the country.
Stem cells. People have been talking about once we have your spinal cord being injured, like we indicated today, it is a permanent injury leading to all those permanent problems, including paraplegia, quadriplegia. There's a view that stem cells might come in and help the picture. What is the view on this?
Unless, of course, there's more research which just hasn't come to the fore yet. The major issue with stem cells is that we're still trying to understand how to channel the growth or the development potential, because the last thing you want is to put something in a confined space like the spinal cord or the canal, which becomes something that it shouldn't be, like muscle.
Okay.
So that is the main problem, how to find a way of putting the correct type of stem cell that will develop in the correct type of way and not overdevelop either.
So there is a future, but it needs to be further developed.
Absolutely.
Dr. Makambeni, Dr. Toron, thank you very much for joining us this morning. I hope that with a little bit that we have done, we have shown how important the spinal column is, how important it is that we should look after ourselves, and also how we should behave when we get to people who have been injured or in an accident scene. We'll visit the subject and spend a little bit more time on how to manage these patients in the long term. Go lona botlhe he barati babugi ba tshegetsi le ba manokeng ba lenaneo lena re itlhokomele mebileng ka setjana le metsameng yohle ya rona gore le se la iphumana le le maemo ana bosula ene re bua ka ona tsatsing la kajeno amrena wa tsohle a tlaletse hantle re sa ntse go le ka rona he ke tsatsing la kajeno. We'll be back next Saturday with a heartburn le sokolla banna, so don't miss it here on SABC2 at 8:30 in the morning. O songa phoswa makube xhosi ube hele a re kopaneng hape bekeng e tlang. Thato ha ile amrena. Thanks for joining us today. From me, Dr. Victor Ramoresi Ramathesile. Ya khawda yaya. Namane tshehla mutangwa mletsa. You take care.